Hey friend, welcome to the Vet Nurse Hacker. I'm Vicky, vet nurse specialist and your personal hype squad in scrubs. If you're tired of textbook advice and ready for the real, messy, hilarious side of vet nursing, you're in the right place. We're talking hacks, hard truths, and the stuff they definitely didn't teach you in school. So let's grab a coffee, roll up those sleeves, and get into it. Hey fam, welcome back to the Vet Nurse Hacker. Today's episode is a technical one and something that will probably get talked about a bit on the Vet Nurse Hacker podcast, nutrition. Why? Well, this veterinary nurse has a VTS, a VNS in nutrition, and a passion for feeding nutrients as medicine. This episode is called Fueling Recovery, Hospital Feeding Strategies for Renal Cats and Dogs. It's time for Nursetrition School. Today, we're diving into something that absolutely nobody wakes up excited about, but that totally changes patient outcomes. Hospital feeding for renal cats and dogs, specifically chronic renal disease. And look, I get it. Renal cases are the ones that give you flashbacks to that one cat who refused to eat, no matter how gourmet your offering was. It's rough. But here's the thing. Nutrition is medicine for these patients. A renal patient not eating isn't just being picky. It's like trying to run an ICU on backup batteries. Today, we're going to break down how to fuel those patients without frying their kidneys or frying your patients. Let's talk about how we can understand renal disease in our hospital patients. All right, nerd alert. We need to do a super quick renal refresher. And I promise, no scary flashbacks to vet nurse school. You can keep your coffee, no pop quiz coming. There are two big renal beasts we need to mention. We've got CKD, which is our chronic kidney disease. This is the slow burn, the grandma's kidneys of the vet world. This is our progressive, sneaky, shows up with vague complaints. Weight loss, PUPD, vomiting, maybe a little of the grumpies. And then we've got AKI. This is our acute kidney injury. This is the drama queen, shows up uninvited, wrecks the place in 24 to 48 hours. This is usually caused by something rude, like toxins. Here we're going to do our shout out to lilies and grapes. It is often ischemic or severe infections. But here's where it gets interesting and rough. Both types come with delightful extras. Appetite? Gone. Nausea? VIP access. Muscle wasting? Front row seats to the atrophy show. Why though? When our kidneys fail, whether that's slow or fast, they stop doing their job. And that job is filtering out the garbage, urea, creatinine, or all the usual suspects. And that stuff backs up into the bloodstream. Hello, uremia. And basically poisons everything. So we've got uremic toxins mess with the gut lining. It slows gastric emptying and makes the patient feel like absolute garbage. That leads to nausea, vomiting, bad breath, you name it. And then let's not forget, we get electrolyte imbalances, low potassium, and that equals floppy muscles, metabolic acidosis, and acidic blood equals feeling like you've been hit by a truck. We get dehydration because the kidneys are leaking fluids like a broken faucet. And the cherry on top of all of that, then get protein catabolism. If the body isn't getting fuel from food, it starts breaking down muscle for energy. And since muscles are full of protein, guess what? Protein broken down gives you more urea. More urea gives you more nausea. More nausea, you stop eating. You stop eating, no protein. Where do you then have to get protein down from? Your muscles breaking down. It's a vicious, depressing circle, and your patient feels crummy on a cellular level. The kicker, their bodies are basically on a slow roast. Metabolic waste is building up, they're dehydrated, they're losing protein mass, and the appetite is tanking. No wonder they don't want dinner. And so when they're not eating, they're not just, oh, poor Bubby isn't hungry. It's dangerous. They lose lean muscle, their immune system tanks, they get weaker, and then plot twist, their kidneys actually get worse. Bottom line, feeding them is not optional, it's life support. Calories equal muscle preservation, which equals healing potential. Food is fuel, food is medicine, food is how we fight back. Think of it like this. Your patient's body is a car. Normally, the kidneys are the oil filter that keeps the engine clean and humming. But in CKD or AKI, that filter is busted. Now they're trying to run on dirty, sludgy diesel fuel. The engine chokes, sputters, and overheats. Now imagine this. On top of the dirty fuel, the car's running on empty because the fuel gauge, the appetite, is broken too. So now you've got no fuel plus a dirty engine, and that leads to breakdown. Feeding them is like pulling into the pit stop and giving them premium, clean fuel that doesn't stress the system but keeps the motor running long enough to get them back on the road. So yeah, it's a big deal. And why hospital feeding is about way more than calories, it's about survival. So let's talk about specific nutrition goals for our renal patients and mostly for our chronic kidney guys. With AKI patients, there is a little bit of finessing because it can depend upon the toxin, the breed, the duration. So we'll focus most heavily on our CKD patients. And let's have a look at what these fussy kidneys actually need. And we're going to break it down into really this renal nutrition 101, but let's make it snackable. So goal number 1, we'll talk about calories without chaos. Now, we're not just going to toss calories at them like Mardi Gras beads. We want smart calories, enough to prevent muscle wasting without loading the kidneys up with metabolic junk. Now, cats need about 60 to 70 calories per kilo per day. And dogs need slightly more at about 70 to 80 calories per kilo per day. Now, if we're just adjusted for illness and stress, so we are going to bump it with an illness factor that's about 1.2 to 1.4 times RER. Now, again, that is going to depend upon each patient. You may need to bump that up slightly higher if your patient needs that. And sometimes we may need to go on the slightly lower end. So again, that is an illness factor for some of these patients, but we can tailor that if we need to. So the real goal here is we need calories to go in, we need muscle to go on, and we need to keep the kidneys calm. So first goal here, calories without the chaos, keeping the kidneys calm. Goal number 2, we need protein, but we need to make it classy. We need classy protein. PSA, it's not 1995. We don't starve the kidneys anymore. And yes, it's something that was a thought back in the day. Cats especially are protein addicts, as we know. And if there is a thought, and it is commonly said that renal patients need low protein. But if you do cut their protein too low, they'll raid the muscle reserves like looters at a protein party, and we just can't do that. Dogs, they are a little more chill about protein, but they still need moderate amounts. So what we want is high quality digestible protein that's going to give us less byproducts and less kidney stress. So think of it like this. We want chicken breast over hot dog mystery meat. That is giving us high quality, easily digestible protein source over something that is less digestible and more of an unknown source. So we typically target dogs about 14 to 20% on a dry matter basis for our protein, and cats about 26 to 32%, up to 35% protein on a dry matter basis. But the most important thing is quality more than quantity here is really, really important. Digestibility and quality more than quantity. Because when we skimp on protein, we get side effects, muscle wasting, immune crashes, slower healing, and we absolutely don't want that. Now, nutrition goal number 3, keep phosphorus low. Phosphorus is the toxic BFF that kidney patients need to ghost. We do not want excess phosphorus. When kidneys fail, phosphorus builds up in the blood, and that leads to even faster kidney deterioration. And so we are going to target levels in both dogs and cats that are about 0.3 to 0.6% on a dry matter basis for our phosphorus. Now, nutrition goal number 4, fat is our friend. And we have 3 energy-giving nutrients. We've got protein, carbohydrates, and fat. And of the 3 energy-giving nutrients, fat gives twice the amount of energy calories than the other 2 energy-giving nutrients, protein and carbohydrates. So more fat gives more energy, and then the less amount of food volume is needed to be consumed. Now remember, these guys are typically nauseous, typically don't eat as much food volume, and we want to be really careful about one of those energy giving nutrients, protein. We want to be careful about how much of that nutrient they're giving. Thus, we only have 2 other energy giving nutrients left to choose from. And so if we can choose from one of those energy giving nutrients, then that has twice the amount of calories, then that is a positive thing for us. The key when we're dealing with this is that we need to be really careful about how we feed it. The good thing is that because fat is calorie dense, is that we can feed it without spiking kidneys or without spiking BUN, and that it can help with weight gain because it does give twice the amount of kilocalories as protein and carbohydrates. However, higher fat doesn't just mean feeding them a whole lot of bacon or a whole lot of bacon grease and going, yep, I'm done. We need to be feeding fat mindfully and feeding them up on highly digestible fats. And we also need to be particularly careful in dogs with patients that have the comorbidity of renal disease and pancreatitis or other fat digestibility diseases. Now, nutrition goal number 5, we also need to be mindful of our micros. Kidney patients leak vitamins and minerals like a sieve. Potassium, we need to watch for hyperkalemia, especially in cats. We may even need to supplement this, and sometimes IV fluids aren't always enough, and so we do need to be very mindful and be monitoring this. Also, B vitamins, remembering that they're water soluble, and these guys are urinating frequently, and our kidney patients are basically peeing them out faster than a greyhound after a rainstorm. They can develop B vitamin deficiencies really quickly. When we get some of these micronutrient deficiencies, that can add to poor appetite. We can see weakness, even neuro issues. So we want to be making sure that we are sometimes supplementing them, but also replacing them nutritionally if we can get them to eat, which is great. This episode is brought to you by Vet3 and by Uncage Me, the radical reset for the human behind the healer. If you're a veterinary professional who's been feeling the quiet weight of fatigue, emotional exhaustion, or just that sense of being lost behind the scrubs, Uncage Me was designed for you. It's an 8-week guided journey back to your identity, your boundaries, and your self-worth, because you were never meant to do this much, this fast, for this long. And you don't have to keep carrying it all alone. Learn more and join the reset at vetxr.com. That's www.vetxir.com, or find the link in today's show notes. Now, if you've gotten this far in the podcast and you have stepped through all of that, that's pretty heavy stuff. You are already a step ahead just by thinking about these goals. Most people, they just get out a can of recovery food, AD, and they just toss it in a cage at a renal cat or at a renal dog and hope for the best. Not you, if you're here so far. You're about to feed like a freaking nutrition ninja, and you are about to hit these guys on the head and go to the next level, and I'm so excited for you. So this is where it gets really hands-on, because very rarely does a renal patient stroll into hospital, sit down politely, and tuck into their renal diet like it's 5-star dining. No way. They absolutely make us work for it. And honestly, how we feed them can mean the difference between alive and thriving and, well, maybe not making it out the door. So let's break down the real world options, because this is where the magic and the mess really happens. So first things first, we have voluntary feeding. This is the best case scenario. This is where they eat on their own. You don't have to chase them around waving a spoon like a desperate grandmother at Christmas dinner. But let's get real. Sick patients eat less. Renal patients, they're nauseous, they're smell sensitive, and pretty sure that food is the enemy right now. Here's some ways that we can make it work. Firstly, warm the food to body temperature. Cold food is like fridge leftovers. It's just gross. Pop it in the microwave for 3 to 5 seconds, or add a little warm water. Help release the oils of the food and make it smell better. Hand feed. Yes, you're officially their personal butler now. White gloves are optional. Offer strong-smelling, highly palatable foods. Recovery diets or lightly warm therapeutic canned diets may absolutely be indicated while they're in hospital to help get the feeding process started 100%. Create a low-stress feeding environment. No barking dogs, no metal bowls clanging, cage doors slamming shut like a rock concert. Calm the vibes. Soft lighting optional, and your soundtrack may or may not be indicated, but if it helps, go for it. Now, if voluntary feeding's not working, we may need to move from that level to the next level, which is assisted feeding. AKA, we are doing this whether you like it or not. Now, this is for the ones who won't eat but aren't critical enough yet for a feeding tube. So we do have some options. Option 1 is a syringe feeding, if you dare. Now, some tolerate it. Some look at you like you've insulted their ancestors. Now, do I recommend syringe feeding? It depends. Do I recommend forced syringe feeding? Absolutely not. If it's gentle and tolerated, syringe feeding can be a very useful tool. If it's stressful, messy, and feels like wrestling a tiny, angry lion, walk away. Forced feeding can create food aversions, not to mention the risk of aspiration pneumonia, and just no one has time for that. So if we are going to go down the line of syringe feeding, here are some tips. Thin or thicken the food to a good texture. So when you are squeezing it out of the syringe, it comes out just right, Goldilocks. Think smoothie, not paint, just to a beautiful texture, and test that first. Don't wait until you've got your patient there before you test it. You want it a nice texture first. Do small volumes at a slow pace. Patience is a virtue, and also helps with having a clean scrub top at the other end. Warm the food a little with warm water to help boost the smell and the palatability. Remember, smell sells. Use some appetite stimulants. They're the backup dancers for your feeding plan. Hello, mirtazapine, we see you. Remember that not if as soon as a pet's struggles, that's it. There's no forced feeding here. Now, we also want to be managing nausea for these guys. Be their advocate. Most renal patients are battling constant nausea, especially in hospital. So we may need to talk to the vets and have a conversation about antiemetics. often these guys, antiemetics are not nice to have, they're essential. So don't be shy if you notice those signs, licking lips, turning head away and swallowing, to have a conversation, to pass on that you're noticing these signs, because we may need meropenem or dancetrol, metoclopramide, whatever it takes to have these patients not view food like an enemy. And if we need to go up a level in our nutrition support, we always have feeding tubes. And this is when voluntary feeding becomes a fantasy. It's tube time. And the easy option, of course, is an NG, a nasogastric tube. This is quick to place, perfect for short-term feeding. The con is that it's small bore, meaning it typically liquid diets only. And cats love to paw at them like just toddlers yanking off the hats or at playthings. They always are pouring at them. But a lot of stew type textures you can actually blend with water, just count your calories, and pass them through some smaller bore tubes, which is really good. We then have esophagostomy tubes, E-tubes. These are chef's kiss for medium-term feeding plans, which for CKD patients, I have actually known quite a lot of CKD patients, particularly cats, do really, really well with E-tubes. They do great with them. Now, they do require an anesthetic, minor surgery to place them, but they recover really well. The problem is that they need to not be critical, so it depends for the anesthetic. They need to be stable for that. So we need to get them to that place first before we can place the tube. But once a tube is placed, they're easy to manage at home with the right instructions and care, and owners can manage them really well with the right veterinary support. So that's great. However, golden rule, place tubes early. If you wait until that patient is skeletal and cachexic, you are fighting an uphill battle. So if we can feed them before they become the visual definition of frail, then we can get a better outcome. So some tube feeding tips, if we can liquidize therapeutic diets and feed those, we are going to get a better outcome than if we are using human liquid diets. They're not always possible for really tiny bore tubes, but that is always, if we can do that, a first step approach and a preferred approach. We're always, as we know, going to break our feeds into small, frequent boluses and avoid overwhelming the sensitive GI tract, and always use our calculations to calculate that out. And then flush, flush, flush before and after every feed. Nobody wants that clogged tube at an inappropriate time. Well, that during an emergency, during 2 a.m., at the most inconvenient time, they always seem to clog. So we've had a look at some of our, at CKD, AKI, at our goals of nutrition and some diet options, at some ways to feed. But what's on the menu? What are our diet choices? And this is where things get interesting, because choosing what to feed is the exciting part. As the VTS in nutrition and the nutrition nerd, remembering this is nurse-trition school, it honestly is half art, half science, maybe 3/4 science and 1/4 art, let's be honest. And that 1/4 art is where the patient comes into it and understanding the patient's preferences. But the 3/4 science is the really important part. And let's jump into it. Now, the first diet option that is for these hospitalized renal patients, that's typically always on the menu, is our recovery diets, like Royal Canin recovery or prescription diet AD, those types of diets. They are super, super palatable, great for these guys who are like, nah, thank you, nothing is interesting to me. But the problem with them is that they are high in protein and really high in phosphorus. And so while they can be great for helping us stabilize our patient and in the really short term, because remember that no matter what, in any case, fed is best. We need to get these patients we need to get patients in general eating. Fed is best. As a general rule, there are some exceptions, of course. As a generalized rule, fed is best. As all things nutrition, as a general rule, there's always going to be an exception. We need to get patients eating. Their bad side is that really high in phosphorus, because of course it's a recovery diet. When you're vomiting, diarrhea, what do you lose? And high in protein. And so the other problem is that we're often doing rapid diet changes. You know, they come in and maybe they're only eating a little bit, maybe they're not really eating, maybe they are eating okay at home, but they come in and then wham, all of a sudden we're feeding something new. The GI tract maybe doesn't like that. And then the goal is to transition to a renal friendly diet once they are less fragile, once they've been discharged. So that is often a option for really critical immediate intervention. Downside, not exactly the most renal friendly, option, but is super palatable. The next option that we have is, of course, our renal foods. They are our therapeutic renal foods like Royal Canin Renal, Hills KD, specifically designed to be fed to these CKD patients. They are formulated to be fed to these guys long term. Amazing. That's exactly what they are designed to do. Nutritionally complete and balanced for these guys in every way. They are controlled in protein, controlled in phosphorus. And again, that's one of the misnomers that we hear all the time: low protein, low phosphorus. They're not actually low. They are on the lower end, but they are controlled is a better way to say it, because again, these patients still need these nutrients. They're still essential nutrients. They would be in a very bad way if we've just got low levels of them. So they're controlled in these nutrients enough to have enough protein and enough phosphorus, but not so much as to cause further damage to kidneys. But again, the risk that we have is of creating food aversion, and food aversions are very, very real problems that we have for these hospital patients. And so the challenge that we have is we've had these patients in hospital in stressful situations, barking dogs, banging in cages, strange people, food left in cages unattended for long periods of time. We're nauseous, we feel unwell, we've got sore legs with catheters and fluids and blown veins and bandages and, you know, all kinds of things going on. And there are only so many limited brands available for these therapeutic renal diets. So then if we have a patient that refuses to eat them when they go home for the long term, the options are limited. So then what's our other option? And third option is a surprise, think outside the box option. And this is where we start to look at nutrients rather than brands or labels. And this is, I posted about this on Instagram the other day, where I posted and said, believe it or not, Hill's Prescription Diet ZD is one of my favorite diets to feed to my hospitalised renal CKD cats. And we are going to take a little bit of a detour here and talk about why that might be and why it might be a surprise entry for this. Now, before I do, I just want to say this is not sponsored in any way, shape or form as we talk about any of these brands. It's just important that we understand and we talk about how nutrition supports disease states. And this is just one singular example of how nutrition is supportive in a way that we may not expect. So let's run the numbers based on our current data. And this is all at the time of recording this podcast. So we've already spoken about our key nutritional factors, and key nutritional factors are just the nutrients that play a really particular important role in any life stage, wellness state, disease state. So for this case, obviously, we're talking about renal disease. And as we said, we've already spoken about protein. We are targeting an upper maximum target of 35% on a dry matter basis. When we look at feline ZD, the feline ZD has 34.3% on dry matter basis in it. which is great, less than our target amount. Now, phosphorus is the only nutrient that is over our key nutritional factors that we look at. And the upper limit of phosphorus that we want for renal disease is 0.6% on dry matter basis, as we've said. And at the time of making this podcast, ZD, feline ZD, has 0.67% dry matter basis of phosphorus in it. So again, only fractionally over what we want. And if we were to compare this to other foods, it's actually really, really a very reasonable amount. Now, sodium, the upper limit that we want, as we have said, is 0.4%. And ZD has 0.32% at time of this podcast on a dry matter basis. Potassium, we want below 1.2%, and ZD has 1.1% on a dry matter basis. Now, on top of that, the other reasons why I like it, ZD being a hypoallergenic diet, is gentle on the GI tract, making it great for fast transitions. And I find it really palatable when I mix it with a little bit of warm water. It makes the odor of it really strong and pungent and changes the texture into sort of a really soft, fluffy texture. And again, I just want to say, not an ad in any way, shape, or form, just a real life example of a clinical win where an unexpected therapeutic diet fits this case example in a way that maybe we may not expect, because we're looking at nutrients, not at labeling. And so these nutrients fit this case example well. And so this is why I like this example, that one example that I'm using for, again, these CKD cats. I find it very helpful for my patients in my lived example, in my lived experience. And again, you may have your own personal preference. And so basically what I'm saying here is that we don't have to be stuck to the label says renal, we have to feed renal. Oh no, they've got a food aversion. What do we feed after that? It's just a reminder that other therapeutic diets can check most of our renal boxes without that risk of lifetime food aversion. And so please always read labels, think creatively, and when in doubt, think about the bigger picture, which is keeping the patient alive and happy enough to want to eat tomorrow. Feeding these renal patients isn't just calorie cramming, it's strategy and finesse and sometimes just sheer stubbornness. So start early, be flexible, think outside the box, and remember, nutrition is medicine, and sometimes food is the best prescription that honestly they get all day. Some patients will straight up refuse therapeutic diets at first. Don't panic. It's okay to transition slowly or use topper techniques like a sprinkle of tuna in spring water. Not the tuna meat, just the spring water without the salt to tempt them into eating. Now, here are some top tips to help. Start with small, frequent meals. Giant turkey dinners and renal patients don't mix. These renal patients can't handle feast and famine. So we're going to think tapas here, not Christmas dinner. Feeding little and often and with grace is going to give us a much better outcome than feeding a big bowl, putting it in the cage and walking away. With their nausea, little and often, you're going to get more calories into them than just putting a big bowl of food in. Warm the food up. As we've said, cold food reduces smell and the texture, and that's going to reduce appetite. Warm it to body temp. Basically, we are going to offer them their own little spa meal. Hand feed if you must, basically like a royal falconer, make them feel fancy. Respect their limits. Force feeding is just going to be stressful. Watch for those signs like they've had enough, lip licking, head turning, backing away. Push too hard and you're just losing trust and enhancing the nausea. Slow, steady, chill wins the race. Stay consistent. Aim for a feeding schedule if you can. Their predictability can help to reduce stress and aim for better intake and fewer food battles, particularly if it's a patient that's going to be with you for a few days. If you can stick to the patient's schedule from home, that can sometimes be very helpful as well. Manage nausea and appetite early. Medications are our friends. We don't want to wait until they're already in a tailspin. Proactive is powerful. We're thinking meropenem or dansetron, mirtazapine. Have the A-team ready and have the conversation with the vets. Feed cats on plates and shallow dishes to help them avoid getting food stuck in their whiskers, because we know that cats are fussy little fiends and don't like their whisker fatigue. Flat, wide plates is going to equal happier cats and fewer, ew, what is this look? Don't leave food sitting for hours. Food sitting in cages equals food that goes stale, stinky, and increases and contributes to nausea. The longer that it sits there, the less appetizing it becomes. So serve fresh food and remove uneaten food after, half an hour, if you can, an hour tops. For cats, if you can, separate food, water, and litter trays because, cats are fussy fiends. If possible, space it out. Cats don't actually like food and water sitting next to each other. They actually prefer to have them away from each other. So having those items separate from each other can also increase their desire to consume food. Feed in a quiet, stress-free environment, lower the lights, calm vibes, no noisy neighbors. If you can feed them out of the cage, that can help. Obviously, pat them, calm voices. We're pretty much turning it into a 5-star dining experience. Sometimes you may even need to add on a feeding charge in the same way that there is a nursing charge to some of these critical patients, because it does take so long to feed them and get them to eat. But food is still medicine. It's still a critical part of the treatment plan. If you need to charge for that, food is fuel and fuel is life. Basically, hospital feeding isn't just stuffing calories in like it's, a duck at Christmas. It's strategic, it's gentle, and honestly, it's an act of clinical love. So start feeding support early, pick your weapons wisely, and remember, a full belly today is going to equal stronger kidneys tomorrow. Okay, let's talk about real life, the world where you do everything right, warm food, calm vibes, hand feeding like a saint, and the patient still looks at you like you've offered them a bowl of pebbles. Renal patients are notoriously tricky feeders, but there are tools we can lean on to help. So let's talk about a few of them. Firstly, we have nausea management. If the kidneys are cranky, then often the stomach is even crankier. Uremic toxins wreak havoc on the gut. We get delayed gastric emptying, inflammation, and nausea. And when your patient is nauseous, it doesn't matter if you're offering Wagyu beef, they're not biting. So the golden rule is if you think they might be nauseous, they are. Treat that first, feed later. You can have the best, most tasty, most delicious smelling food and they still won't eat. So in your nausea management toolkit, we are going to have meropenem, syringe, our NK1 receptor antagonist. Now, this controls vomiting and may have some anti-nausea effects. It's once daily dosing and has been, it can be given under vet direction. We also have ondansetron, which is our 5-HT3 receptor antagonist, and this is great for inappetence and nausea. And this can be used alongside meropenem. We also have metoclopramide, and this is a dopamine antagonist, prokinetic. And this is useful if you're dealing with delayed gastric emptying, think sluggish guts. So these are often used in combo, and combo therapy wins. Nausea is multifactorial, so hit multiple pathways when needing. And timing is everything. We want to pre-medicate before trying to feed. If they've already associated food with nausea, it's typically game over. And then we have hello food aversion. So if we can stay ahead of the nausea wave, then that's where we typically get a win. Now, the next tool that we have is appetite support. If we have our patient still being a little bit stubborn, then we can have endochemical persuasion. Typically, the most common one that we use here is mirtazapine. Most commonly here, we'll use oral or injectable forms, but there is a transdermal option as well. Now, we always want to be sure to microdose, especially in the geriatric, or the grumpy. Now, as a bonus, there is a mild anti-nausea and antidepressant effects, but we typically still will use anti-nausea medication or an anti-nausea protocol. With mirtazapine, it's often not used on its own. Again, the key is start early. Don't wait until they've lost condition. Appetite stimulants are most effective when the patient still has some interest in food. Once they become completely anorexic, the response is much, much less reliable. Now, if we are giving mirtazapine, monitor closely. Some patients, especially cats, can have a weird hyperreactive response or vocalize. And so if you are giving it to an owner to take home, please warn them, or we may need to adjust the dosing. Now, there are behavioral tricks that we can also use to support feeding. And look, we all know cats come from out of space, and I'm 100% certain that cats can smell your desperation. Dogs are a little easier, but cats, they know when you are trying too hard, and I'm 100% certain they will punish you, and they do punish you for it. So here are here's a checklist for your behavioral, for some tools to support feeding from a behavioral standpoint. Number one, quiet room. Of course, as we've said, no barking, slamming doors, no having a wild raging party, clanging bowls. We're thinking Zen feeding dojo. Lower the lights if possible. We don't want to be screaming hospital fluorescence. Dim it down. We basically, if you think it's nice and calm, you go in there for your Menti B break, have a nice Zen lunch, then your patient is going to have a nice Zen lunch as well, nice and relaxed. Sometimes some patients will benefit from the no pressure, offer food calmly, walk away, don't stand and stare at them approach. Some patients will benefit from the feed them, stay and pat them, and be their companion approach. You may need to personalize it and get to know that particular patient to know which approach is going to be better for them. That takes a little bit of getting to know them and individualizing the plan. As we said, serve it fresh. Don't let it sitting there for more than 20, 30 minutes. Dump it an hour max. The longer it sits there, the more it's going to stink, the more it's going to make them nauseous. Comfort is definitely counts. Feed them outside the cage if you can, in a comfy place, on a nice bed or a towel, somewhere away from the place they've been sitting, feeling sick, ill, away from home. Make them feel happy and secure. Read their body language as your early warning system. If you are seeing lip licking, head turning away, moving away from the bowl, there can be signs that they do have nausea, that they're done, that they need some extra support. So again, if you ignore it, you run the risk of a food aversion, you run the risk of them not eating. So either intervene or report it. Just don't ignore those signs. It can also be signs of stress. I should say stress management is another component that we need to manage with these guys. Now, finally, we need to monitor their intake. Now, in vet med, if you're not tracking, we're guessing. And guessing in really sick patients can get us into trouble. So charting is really important, and our renal patients are masters of hiding weight loss and dehydration. Even a subtle dip can snowball into really severe problems. So it helps to know what's going on to be able to adjust plans, what medications they've had, all those sorts of things. So we diet plans are so important. We need to know to record how much was offered, how much was eaten. And sometimes we do have to estimate how much was eaten. We need to record the type of food, the method it was offered, if it was hand-fed, syringe-fed, free access, what meds were given, if they were given before meals, that sort of thing. The behavioral notes, also really important, and also rarely recorded. So behavioral notes are things like interest levels, aversion, signs of stress, those kinds of things, and then complications, so vomiting, diarrhea, those sorts of things. Now, a nutrition plan and a food diary makes handovers so much easier. We chart and record our patient's progress. We should also be charting the nutrition plan. And it happens all the time where the next shift comes on and they're like, does anybody know what so-and-so's eating, what they like, how much they're eating, how they like it to be fed? And no one knows. So then they just scoop out a couple of tablespoons of whatever's in the fridge, put it in a bowl, chuck it in the cage, close the door, and move on to the next patient. And guess what? That patient's still not eating. It happens all the time. And again, no hate. Everyone's just busy, but we can do better. Remember, renal patients aren't just fussy. They're fighting real physiological battles and managing nausea, boosting appetite, reducing stress, and meticulously monitoring intake are just our absolute best weapons in supporting these guys. I know it's hard, but stay patient, stay flexible. And remember, sometimes saving lives isn't about another drug or another drip. It's about the quiet magic of a good meal delivered with intention. All right, team, let's pull it all together, because hospital feeding might not be glamorous, but it's one of the most powerful tools in our arsenal. Let's hit the big points one more time. Early proactive feeding equals less muscle loss and faster recovery, better outcomes. Waiting until they're skeleton, too late. Get in early, feed before they fail. Tailor the plan to the patient, not your schedule, not the textbook. Sick kidneys don't care if it's inconvenient. They need calories, nutrients, and support on their terms, not ours. Small meals, warm food, big patients. Think tapas, think spa service. We're not running a buffet. We're delivering fuel, comfort, and care one bite at a time. Here's what I really want you to remember. Nutrition is therapy. Food isn't just food. It's medicine. It's cellular repair. It's immune support. It's the difference between surviving and thriving. Hospital feeding, it's quiet. It is thankless. It's behind the scenes. But it's one of the most powerful ways we save lives. One scoop, one syringe, one tube feed at a time. So next time you're warming up food, logging intake, or hand feeding a cranky renal cat who looks ready to throw paws, remember, you're not just feeding, you're fighting, you're healing, you're literally putting life back into tired, hurting bodies. Now go forth, warm the renal food, warm therapeutic food, load the syringe with love, fight the good fight, and show those kidneys who's boss. And that's a wrap on today's episode. Thank you so much for hanging out with me and diving deep into the world of hospital feeding for our renal warriors. I know this stuff isn't always glamorous, but it's powerful. The quiet, behind-the-scenes work you do at that feeding station, it's life-saving. And today, you've added even more tools to your toolkit to help those patients fight harder and heal faster. If you found today's episode helpful, inspiring, or even just mildly entertaining, don't forget to subscribe, leave a review, or share it with a fellow vet nurse, tech, or vet who could use a little extra fire in their feeding game. We're all in this together, and trust me, there's always more where this came from. Until next time, stay kind, stay curious, and I'll see you on the next episode of the Vet Nurse Hacker.